Okay, you can hear me.
Yes.
You can see slides.
Yes.
Excellent. Okay. I came back from SMFM last week with the flu. So if I sound like that, I sound a whole lot better than I did last week. So stay safe out there, wash your hands, and beware of the virus spreading small humans and big humans. Okay, we are going to talk about what I have titled Self-Respecting MFMs Use Progesterone for Methamphetamine Use Disorder, ... while they study it. So I am going to present on behalf of my study team, and hopefully this will be 30 minutes of entertainment and some knowledge snacks for you. So I'm going to present the prompt, which is the title of my study, and I'll talk about it a little bit more. It was funded by NIDA R21 and the Family Friendly Initiative Supplement. And these are my disclosures, which are not relevant to the study. I do want to highlight, especially for WAG Journal Club, the Family Friendly Initiative Supplement is for investigators that have had a family life event, including the birth of a child, which happened right at the beginning of my study. And it sort of allows for continuation. It's a modest amount of money, but was really instrumental in being able to continue to fund my R21. And so just elevating that for the group so that you know that that is available out there. Okay, so I am going to talk a tiny bit about methamphetamine use disorder, then we'll talk about progesterone, then we'll talk about the results of the prompt study, and then I'll talk about next steps, and hopefully we'll have time for discussion at the end. Okay, so I know this group knows this a lot, but we are going to do the obligatory thing of repeating these things. So as we very much know, substance use disorder is really characterized by uncontrolled and distressing use and cravings with and without use. I do think that that's an important thing to emphasize is cravings, and I think particularly for women is an important symptom that we really need to think about and target when we're thinking about our interventions. It's a leading contributing factor to pregnancy-related deaths and pregnancy-associated deaths in the United States. That's a totally different talk that I give. And the mortality peaks at 6 to 9 months postpartum, most frequently after a period of abstinence in pregnancy with a subsequent return to use. For methamphetamine use disorder, we hear a whole lot about opioids. I spend a lot of time thinking about meth and methamphetamine use disorder, and it's certainly a life-threatening condition among peripartum people. For those with meth use disorder alone, there's a 1 in 10 chance that they'll have a severe maternal morbidity event or death in pregnancy or within a year postpartum. And for those with meth and opioid use disorder, that increases to 2 in 10. So I'm going to very briefly go over what are our tools in our armamentarium for medications for methamphetamine use disorder. I want to be crystal clear for the WAG group that none of this is studied in women. So these studies that I'm about to go over are absolutely primarily studied in cisgender men and transgender men. So not evidence-based, but rather evidence-informed, which is my favorite term to use when adopting interventions studied in other populations for pregnant and postpartum people. So the ADAPT-2 trial, which is this trial, the intervention was naltrexone, 380 milligrams IM every 3 weeks, and bupropion, 450 milligrams extended release daily. This was a randomized control trial by Trivedi et al. It's published in the New England Journal of Medicine. And they did a very interesting study design. They had 2 phases, so everyone kind of crossed over. The response they were looking for was urine negative for methamphetamine. So the important part about this is that there was a 13.6% response in the groups that got medication, and 2.5% in the placebo group, with an 11% improvement overall. So really, really modest, but in the landscape of not a whole lot of interventions that are data-driven, this is, I think, an important intervention for meth use disorder. Okay, again, very clear. Not studied in pregnant and postpartum people. I'm going to repeat things that are important to remember. Mirtazapine. So that is our other medication for methamphetamine use disorder that really has a solid base of evidence behind it. So in, again, a this is based on primarily on two RCTs. I'm presenting you here a systematic review and meta-analysis. There are two RCTs that were entirely in men, in cisgender men and transgender men. Everyone got CBT, so cognitive behavioral therapy and motivational interviewing, and mirtazapine 30 milligrams versus placebo. What were the outcomes? Mirtazapine had a modest effect. So there was a risk difference of 14 fewer individuals using methamphetamines in the study. There was no difference really in retention to treatment. There was not really any difference in high risk sexual behavior, although that was a difficult outcome to study. Maybe a difference in depression scores that was a little bit higher. So in the landscape of things that we do for meth use disorder, certainly in my clinic, we do offer these as evidence-informed interventions for meth use disorder with counseling, that there is limited evidence. So for meth use disorder, really the studies that we have available is contingency management, continues to be kind of the thing that we have the best and most robust data for. The matrix model, CBT, 12-step facilitation, and some data around mobile apps for behavioral treatment. The hard part for a lot of these, particularly contingency management, which I think the landscape is changing, but very slowly, is that it is not covered by insurance. So it becomes very difficult to access contingency management. So there you have essentially very high level overview of what are our options for methamphetamine use disorder treatment that is based on some evidence. Okay, now I'm going to segue to progesterone because I entitled this talk that I'm an MFM and I like to throw progesterone at things. Don't worry, there will not be any pessaries discussed here for those of you that get that. Okay, so what do we use progesterone for? Everything, right? Contraception, dysfunctional uterine bleeding, endometriosis, lutein deficiency, preterm birth prevention. That's kind of that. We love to do that in MFM. Postpartum depression, which that will come up at the end, and hormone replacement therapy. So as thinking about, so I want to invite you to think about progesterone now as preventative pharmacotherapy. And we're going to spend the next few slides kind of thinking about how to think about this differently than my MFM training. So progesterone in preventing return to use. So it's a neurosteroid that crosses the blood-brain barrier. So the idea of this is that you give somebody exogenous progesterone that metabolizes into allopregnanolone. Allopregnanolone enhances GABA receptor functioning, and it can diminish cravings and then thereby reducing the return to use. Okay, so getting a little bit more in the weeds for neurosignaling, since this is Journal Club. So this is a really great overview of how progesterone and allopregnanolone work as neurosteroids. So if you are looking for some bed night reading that is not fantasy smut, which is what I read at bedtime, then I direct you to this delightful paper. So in acute stress, you want to think about everything increasing, right? So you have acute stress, your pregnenolone, your allopregnanolone, your cortisol increases, your corticotropin receptor factor increases, and your toll-like receptor 4 signaling increases. So that's your acute stress. Everything goes up. But what about chronic stress? So chronic stress is something constantly happening. Maybe it's substance use disorder. Maybe it's external, it's living in our today's society, which I think we are all under chronic stress at this point. Allopregnanolone decreases, your GABA signaling decreases, your cortisol decreases, but then it increases. And then your CRF and your toll-like receptor 4 signaling increases. So this is sort of unchecked chronic stress that it constantly you're experiencing this. So why neuroactive steroids like progesterone or allopregnanolone? So basically you give somebody back some of that allopregnanolone, it affects GABA signaling, and you get an evening out of all of those signaling pathways. So I have taken something that is extraordinarily complicated and paraphrased this article's sort of essentially really summarizing what progesterone as a preventative pharmacotherapy is based on. So you're going to notice a lot of alliteration in this talk. So postpartum preventative pharmacotherapy. So now we're adding another P in there. So what we know about progesterone in the post-pregnancy and postpartum period. So progesterone goes up, allopregnanolone goes up during pregnancy. It's produced by the placenta. So you're really seeing the peak of it right around delivery. And then once somebody delivers, loses that placenta, you get a precipitous drop in progesterone, and that nadir is really around 12 weeks postpartum. So you'll see this number come back up again, 12 weeks. So that's where we're starting to, so now progesterone as postpartum preventative pharmacotherapy. Okay, there's 3 trials that I hang my hat on in this. So there are 2 trials in tobacco. One was actually done by Ariadne Foray, who was the previous speaker for WAG. And those trials in tobacco use disorders. So these were postpartum individuals with tobacco use disorder, and were given progesterone supplementation postpartum. And it decreased cravings and it increased the number of smoking-free days. There is one trial in cocaine use disorder that was done also by Dr. Foray's group with Kim Yonkers at Yale. And that was a randomized controlled trial of 40 postpartum individuals with cocaine use disorder. And they had decreased self-reported cocaine use and an increase in time to return to use. However, in methamphetamine use disorder, we have no trials until now. Okay, so now we've got some investigating to do. Okay, so this is PROMPT, which is the prevention of methamphetamine use among postpartum women trial. And so the objective of this trial was really to establish feasibility, safety, or to assess feasibility, safety, and establish preliminary estimates of efficacy of micronized progesterone to decrease return to methamphetamine use and cravings among postpartum people with methamphetamine use disorder. Okay, so let's go through some of the methods of this feasibility trial. So a lot of inclusion and exclusion criteria. So we included postpartum individuals within 12 weeks of the end of pregnancy, where that was to really mirror that decrease where we nadir that postpartum progesterone really naders, so to capture people within that window. They needed to be 18 to 45 years old, methamphetamine use disorder defined by DSM-5 criteria. If they had opioid use disorder, they were required to be stable on medication for opioid use disorder, either buprenorphine or methadone for 4 weeks. And I'm happy to expound upon that, there was a lot of the details of why we made decisions was a lot of negotiation with the FDA. So happy to expound upon that in our questions. And then if taking psychiatric medications, the dose needed to be stable for 2 weeks. And they had to be taking some kind of contraceptive method, or at least report a contraceptive method that could be an IUD, it could be a progesterone-based IUD, a barrier method, or tubal ligation, or self-injectomy. The exclusion criteria was any methamphetamine use within 4 weeks. So this is what we focused on was prevention of return to use. So it's not someone that's an active methamphetamine use disorder. Given the mechanism of how progesterone really works or is hypothesized to work, it's really meant to be prevention of, as opposed to treatment of, methamphetamine use disorder. So current or pending incarceration for obvious reasons, very high depression symptoms or anxiety symptoms. They could be re-screened once we were able to stabilize them on medications or other treatment, whatever their desire was. We could re-screen them, and if they were then able to meet eligibility criteria, then they could enroll. Active suicidality, contraindicated sedating medications, and let me tell you, this list was extensive. Thank you, FDA. It really included lots of anti-anxiety medication. So we had to exclude people with any hydroxyzine, any gabapentin, any antipsychotic. And you will see in the consort chart that we excluded a lot of people. Alcohol use disorder that was active in the past 6 months. Psychiatric hospitalization, so you'll see those italicized, psychiatric hospitalization, psychosis, or suicide attempt. At first, the FDA made us exclude anyone with a lifetime history, which I, yes, as I see Caitlin's face, it's like that's a lot of people in our population. And so after a year, we petitioned that this was really a burden that makes this study less generalizable to other people, and quite frankly, we weren't able to recruit the number of individuals that we needed to in the time frame. So we were able to change that in the past 6 months. And then residing within 100 miles from the site, and then some lab abnormalities and vital sign abnormalities that weren't really profound anemia, very high LFTs, TSH that was very elevated. Okay, so what was the exposure? Was micronized progesterone, 200 milligrams twice a day for 12 weeks, and then an identical appearing placebo capsule twice a day for 12 weeks. They did actually look identical, but I really like this picture of Orpheus with the red pill or the blue pill. So I'm making you look at it. Okay, so our co-primary outcomes. So really a reminder that this is a feasibility study. So our goal was 40 participants, really modeled after that Yonkers et al. Paper. Retention over 12 weeks at 80% and adherence to study procedures of 80%. And then safety, so we assessed adverse events and severe adverse events of participants and their breastfed infants. This was really important to the FDA that we studied breastfed infants because of the concern of progesterone and sedation. And then our key secondary outcomes were return to methamphetamine use. So this was assessed by self-report in the past 7 days. So that was assessed weekly. Participants had weekly visits, but only every other week were either in person or required them to mail or connect with our research coordinators to get a urine toxicology for methamphetamine, which was done by immunoassay followed by mass spectrometry and liquid chromatography. And that was done every other week. And then methamphetamine cravings, which was assessed using the stimulant craving questionnaire. It's a 10-item instrument, and then it asks people to rank things like, I think about methamphetamine all the time on a 7-point scale, ranging from strongly disagree to strongly agree, and there's a score from 10 to 70. Okay, so how did we do this? We recruited in our SUPeRAD clinic, which is our integrated perinatal addiction clinic. They were approached starting at 36 weeks gestation, or until the 12 weeks from the end of pregnancy. And in inclusion and exclusion criteria, you specifically didn't see anything about a pregnancy outcome, because people the pregnancy could have ended in any number of ways. So a miscarriage, a stillbirth, a live birth, or termination. You'll see in the results, I'll foreshadow that it was all live births. However, that wasn't there was no requirement for individuals to have a certain type of birth outcome. Enrollment occurred postpartum, and that was at the time of randomization, and they were randomized 1-to-1 progesterone to placebo and stratified by opioid use disorder. And we decided to stratify by opioid use disorders. We thought that was an important co-occurring. I mean, many people had nicotine use disorder. There are many other co-occurring substance use disorders, but because in our clinic, about half of individuals with methamphetamine use disorder have co-occurring opioid use disorder, we thought that this was an important co-occurring substance use disorder to stratify by. And then we did descriptive statistics for our baseline demographics, depression, anxiety, and craving scores. And then we assessed our return to use by intention to treat and as treated. And then we used logistic regression to assess change in craving scores, accounting for time and adjusting for confounders with an interaction analysis for opioid use disorder and medication for opioid use disorder. Okay, well, let's talk about our results. Okay. So we started screening in November of 2021. And that seems so simple when I put that up there. But let me tell you, just because this is WAG and the journal and a journal club, and I get to editorialize the journey of this trial, we got funding in July of that year, right? So we waited for a very long time. So we actually got funding. Sorry, we got July of 2020. And it took forever for us to be able to get a press to be able to make the identical capsules. It sat in the LA Harbor for an extremely long period of time. And so there were a ton of delays in being able to get study medication and to be able to make the capsules. So, you write this, I like to say that your grant is the fiction, right? And then your paper is actually the documentary of what you did. So and we started in November of 2021, but boy, it took us a really long time to get there. And then we ended screening and enrollment in January of 2024. And then by April, because the 12 weeks trial period, we ended in April of 2024. Okay, so we screened 253 pregnant and postpartum individuals for eligibility, and 116 were not eligible. Most, the red box shows you the most frequent exclusion criteria. So most frequently active meth use within 4 weeks, so not eligible. Next after that, they came to us or represented to us after that 12 weeks at the end of pregnancy. And then 33 were those medications that were contraindicated. And if you want to see the appendix, it's in the protocol paper that got sent out for this. The medication list was long and extensive and quite frankly, a pain in the butt. But it was not a negotiable thing. And then you'll also see the history of 30 history of psychosis, suicide attempt, or psychiatric hospitalization. So that was the next most frequent. And that really dropped down to within 6 months once we were able to change that inclusion and exclusion criteria after a year of enrollment. That really happened. So we had 30 people that we had to exclude within the first year, and then in our subsequent enrollment, we really saw a pickup in numbers. So we had 40 individuals who consented for the study, but then after consenting, there were 6 screen fails after consenting, 5 of which were people who were started on contraindicated medications because of symptoms that they were having, and then we had 1 individual with a lab abnormality that we needed to exclude. And by the time we were able to get that issue under control, that person was past the gestational age window or postpartum age window that we could enroll. So that left 34 individuals who were randomized, 18 to progesterone and 16 to placebo. So all 34 individuals had live births. 3 of those were preterm, and they were sort of what I like to call the garden variety preterm, like just a little bit late preterm, not super duper preterm, not where we get worried. Similar, the groups had similar demographics for age, race, and ethnicity, weeks postpartum. Housing, which I think is going to be an important is important here. I want to draw your attention to that, and then also opioid use disorder. So for housing, what I want to draw your attention to is that we had 47% of our individuals were in a residential treatment program, and that will be important when we think about return to meth use and the numbers that we saw in this trial. For opioid use disorder, we had 8 individuals in the progesterone group, 6 individuals in the placebo group, and about roughly evenly distributed between buprenorphine and methadone. Okay, so baseline assessments were similar for both groups. So it's on the relative scale of things, stimulant craving scores that were not super severe. Depression by EPDS, again, were also not super high, but the folks that were really, really high were excluded, and most of these individuals were taking some kind of mental health medications. And then anxiety scores by GAD-7, also similar between the groups. So for our primary, co-primary outcome of feasibility, our enrollment goal, we enrolled 34 participants, which was 85% of our planned enrollment. And as you can see, it sort of was pretty steady over the time that we were able to screen and enroll. And then our retention was 88% over the 12-week study period, and we had 79% adherence to study procedures. For our safety outcomes, there was no difference in severe adverse events between the progesterone and the placebo group. We did have 4 severe adverse events. They all occurred in breastfed infants. All were deemed unrelated to study procedures. They were primarily due to infant respiratory infections that required hospitalization. We did have 1 death that was due to congenital heart disease. This was reviewed extensively by our DSMB and was deemed not related to our study procedures. So for our adverse events, there was the mean number of adverse events for participants related to study drug was higher in the progesterone groups, or not surprisingly, 5.2 versus 2.1 in the placebo, and there was no difference in grade of adverse event. So the most frequent adverse events were headache, appetite changes, vasomotor symptoms, dizziness. And these were not different. These, I would say, are pretty consistent with postpartum changes. Many postpartum pregnancy, postpartum, 1 star, do not recommend, does not feel great. But other common adverse events, there was more common in the progesterone groups, and those included fatigue, the ones that are highlighted, abdominal pain, menstrual concerns, muscular symptoms, and sleep disruptions were more frequent in the progesterone group. And these are rates that would be expected for symptoms consistent with micronized progesterone. So on the one hand, some might interpret it as like, well, people are having more side effects. And I'm like, yes, it also means they're taking the medication, right? Like they're not just bringing us back the pill count in order to sort of have that effect that people want to be seen in a positive light, that they're adherent to the study procedures. They're having the symptoms that we would expect with micronized progesterone, which are those symptoms. So what about our key secondary outcomes, which were, this is the feasibility and the safety are the ones that are the primary outcomes. But just like you, I was if not more interested in this key secondary outcome, which is return to use. So by self-report, there were no self-reported return to use. We did have 2 individuals, both in the progesterone group, that reported a return to use. Our first participant had at weeks 12, or not our first participant number 32 was an individual who was positive at weeks 10 and 12, but it discontinued study medication at week 1. So this is a person that was technically in the progesterone group, but really hadn't taken it since week 1. And then participant 34 was positive at week 10, and then was lost to follow up for week 12, which was imputed as positive. So when we looked at it by intent to treat and as treated, there was really no difference in return to use between the progesterone and the placebo group. And again, we had a really low 11% versus 0, or 5.9 versus 5.9, depending on intent to treat or as treated. And this is really low. This is much lower than we sort of expected based on the Yonkers et al. Study. However, when we were really contemplating this within our group, we really think it's because we have 47% of our individuals are in residential treatment program. So they're receiving the highest level of care, and they aren't using because they are in residential treatment. And we looked at, our numbers start to get really, really small when we look at, who's housed, or as we like to say in the SUPeRAD clinic, the Wilderhood. When they're in the Wilderhood, there really wasn't a huge difference. So what about change in craving score over time? So we adjusted this model. So this is the logistic regression model that was adjusted for baseline BMI, time postpartum, housing, and then we did an interaction testing for opioid use disorder and medication for opioid use disorder. And so because our interaction testing was positive or statistically significant, I'm presenting this by these are our stratified results. So for people who had no opioid use disorder, there was no difference between the progesterone group and the placebo group. And as you can see there by both the p-value and the confidence intervals. Whoever is a statistical purist, I'm presenting this for ease and realize that I don't need both, but I'm doing it for everybody's eyeballs. For those taking who have opioid use disorder taking buprenorphine, there was actually increased cravings in that group, in the progesterone group versus the placebo group. And for those taking who have opioid use disorder taking methadone, there was significantly decreased cravings in that group. So I want to put all the stars and caveats around this. There are 34 individuals in this trial. All right, when we start to get down, the cells start to really include pretty small number of people when we're dividing up who's taking methadone versus not. I do think this is an interesting signal, and it allows us to sort of anchor things, anchor future design of a trial to see, is this a real signal? Do we see differences in people with and without opioid use disorder, even by the medication that they're taking? And I'll further editorialize this and say, I don't, one question that I've been asked is, do I think is it the medication, or is it, and I say usually, I don't know if it's actually the properties of the medication, or if it's that people who end up taking opioid use disorder are different, or taking methadone versus buprenorphine are different than each other, right? This isn't a randomized controlled trial. People needed to be stable. They needed to be stable on one or the other of these medications. And at this point, we didn't have, we certainly offer naltrexone as an option in our clinic. There wasn't anybody who was excluded because of naltrexone, but it is certainly a thing that we don't, we wouldn't have included, no one would have actually met criteria for the study that was on naltrexone, but the numbers would be really, really small. So take this, I think this is an interesting signal. It allows us to think about how to power a future trial and whether these phenotypes are actually different. But I want to be very, very clear that these data really have to be taken with a grain of salt. Okay, so strengths and weaknesses. So we've got an innovative intervention that leverages the unique postpartum physiology. Our sample size was representative of our integrated perinatal addiction population, likely reducing the likelihood of selection bias. And I think including meaningful outcomes such as cravings, which can really affect women more than men. And certainly people in residential treatment programs are still dealing with cravings as an untreated symptom of their substance use disorder. What about our challenges? So our feasibility outcome may not be generalizable to other sites, given our unique integrated perinatal addiction clinic that has a really robust research infrastructure, at least for now, these are dark times. The low return to use is likely due to a high proportion of individuals in residential treatment program. And we're certainly not powered for efficacy, so those results have got to be interpreted with caution. Okie dokie. Okay, so conclusions. An RCT for progesterone as preventative pharmacotherapy for postpartum people with meth use disorder is both feasible and safe. Preliminary estimates of efficacy would really anchor the design of future trials as progesterone as preventative pharmacotherapy in data specific to postpartum people with methamphetamine use disorder. And then if proven effective, progesterone or some other type of progestins could represent the first tailored approach for postpartum people with meth use disorder to reduce cravings, return to use, and ultimately what we care about is reduction of maternal morbidity, mortality, and keeping families together. Okay, so round 2, ding, 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 ding. Okay, so prompt 2.0. AKA potentially right now its working title is STUD-Z, is because it's going to be hopefully a multi-center trial. I'm pitching this to the Clinical Trials Network, which is the NIDA Clinical Trials Centers. Stimulant use disorder, so including both methamphetamine and cocaine use disorder. And the intervention, allopregnanolone. So specifically zuranolone, which is as many of you probably have heard of, zuranolone. Its trade name is Zurzuvae. It is the first medication that is approved for postpartum depression. It works the mechanism that I went through with decreased cravings and working on that GABA receptor signaling, it is the identical idea with postpartum depression, that it's that progesterone, that loss of progesterone really dysregulates all of that signaling, and giving back that allopregnanolone is thought to stabilize that signaling that really leads to postpartum depression. So for a different indication, I want to try, instead of 12 weeks of micronized progesterone, which does have a high symptom burden. Why 12 weeks? That's how the Yonkers et al. Group did it. So that's why we picked the 12 weeks. So to try to, and this was not Zurzuvae or zuranolone was not available. Brexanolone, which is the IV version of allopregnanolone, had just been approved when I was pitching the study to NIDA. So I think this is really like, this is the next, hopefully, if we bite, that will be the next thing coming down the pipeline. We're going to look at both return to use and cravings, as long as this is accepted by the CTN and I can get study medications, And we're going to include qualitative experience of folks with, and really digging into methamphetamine cravings among postpartum people, not just return to use. So this is kind of how I feel about that. For those of you that are old enough to remember this, I will sing you the, are y'all ready for this? Okay. Could not, this is very, 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 very many people to thank for prompt. There, no study is ever done alone. So specific shout outs to the SUPeRAD team, all the folks at PARCA and OGRN, the MFM division, our Center for Human Toxicology, and our residential treatment programs, who were so inviting and allowing us to recruit individuals and do study procedures during their treatment time. Okay. How'd I do? We ready for
good timing.
I can't keep time myself. So, okay, I'm gonna stop sharing so I can see everybody, because it's way more fun for me if I can see people. Okay. If I can stop sharing. Ooh. There we go. Okay.
Thanks,
all
Marcela.
right. Thoughts, questions,
we had
feedback.
We had one question pop up in the chat that I'll read to get things started. How about that, Marcela? There's a question about your contraindicated meds. I'm assuming this is something to do with the FDA process. So if you could talk a little bit more about how those were selected.
Anything that could possibly be sedating. The list was, I mean, I think when we actually counted, I think there were 65 medications that were listed on the contraindicated medications. They basically said anything that is sedating. The concern was around, and I understand the FDA, like, their job is to keep people safe. I understand that. But we felt a little bit hamstrung because we, in order to enroll people, we sort of had to say, like, well, these are the types of medications we might offer you, but you can't be on them if you want to be in the trial. And so participants really had to choose if they felt very strongly about taking a contraindicated medication, then we wouldn't enroll them in the trial. But it was a very extensive list, including like melatonin. I mean, just a lot of things.
So that was my question, Ann Nafziger. That was my question, and I guess I'm still confused about why the FDA was concerned about micronized progesterone and sedating medications.
because they thought that they were worried about over sedating patients. That's what that was their concern. We had many meetings about it, and I sort of had the same.
Can you just provide me with some, I'm not familiar with progesterone causing sedation.
It is listed in the as one of the symptoms, and if you look at the packaging for micronized progesterone, it's listed in the potential side effects that people can experience. Certainly, I mean, allopregnanolone, the zuranolone, that's definitely one of the symptoms that people experience. We didn't see a lot of it in our you know in our adverse events that people attributed it. I think people take micronized progesterone for all sorts of reasons, and it's the things I'm used to hearing more is nausea and vomiting and some bloating and maybe those menstrual irregularities, for obvious reasons because you're giving somebody active hormone, but usually not sedate. Sedation is that is what the FDA was very, very concerned with.
Okay, thank you. I might have to try it for sleep.
Oh, I mean, I just got asked if I was worried if individuals with substance use disorder were gonna misuse progesterone, and I was like, no, nobody misuses progesterone. It's like not a thing that happens, but a lot of concern about it. Okay.
I had a question along the same. I'm
Yeah.
Andrea, I'm an MD PhD student in Minnesota. Did you get a sense of whether sleep improved postpartum for the women on progesterone versus not?
That's a good question. I think we had sleep disturbances, so we didn't actually ask them if their sleep improved. Honestly, I can share. So for everybody, it was 6 people reported sleep disruption, and that was a third of the progesterone group and nobody in the placebo group. So I would say it's probably based on what they reported is the opposite. I'm gonna guess it was because they got all sweaty, because that's a thing that happens.
Well, it's fallen out of favor, but in the probably the mid-90s, progesterone was being used for menopausal hot flushes.
Yeah.
So
Yeah.
I wouldn't think that it would aggravate those, but perhaps it does.
I'm guessing it's one of those, like, much like any hormonal intervention, whether it's for contraception or for menopause, right? There are certain phenotype of individual that responds to it, and there's a certain phenotype of individual that it actually can make the symptoms worse, and we're not good, we don't know what that phenotype is. So that's my hand wavy answer to that question.
I have a question, Marcela. So in the next study, how are you going to deal with the opioid use disorder, buprenorphine, methadone in your study design?
Yeah, so we are going to stratify by opioid use disorder. It's been when designing randomized controlled trials, right? You have to be realistic in who and how many people you can actually enroll across multiple sites. So we are going to attempt to we are for sure going to stratify by opioid use disorder. I think the methadone and buprenorphine requirement is still going to be there, and we will see if our sample size will allow us stratification by additionally by medication for opioid use disorder. We're definitely going to analyze our results with looking at this if there's an interaction. I think it's an interesting signal. We are certainly going to anchor our design analysis that way, but I don't know if we're going to actually have the numbers to stratify both by OUD and MOUD.
Hi, Dr. Smid. Thanks for your
You
time.
can call me Marcella. Thank you. We've
Marcella.
literally known each other for 7 years now.
Yeah.
Thanks. Okay.
That's true. I was wondering about the decision to not include patients with elevated anxiety or depression, because I was thinking of those patients as being potentially more vulnerable for return to use in the postpartum period, which I guess excluding them helps you really like isolate, are you targeting craving rather than depression, anxiety. But also I think of depression and anxiety as a function of like a moderator of driving craving or return to use, if that makes sense. So I'm kind of curious about like that decision there.
So at the risk of sounding like a broken record, the FDA made me do it. If you look, we really modeled this, and this is a little bit, I guess, one of the best, the advice I got was, if you've met one FDA committee, you've met one FDA committee. We really, when we originally pitched the trial, we did exactly the identical inclusion and exclusion criteria that the Yonkers et al. Group did, which didn't have any of, none of the contraindicated medications, the high depression, anxiety. I mean, there was, there was active suicidality, psychosis, right? Sort of the stuff that we all exclude because people who are actively psychotic cannot consent. So to be ethical researchers. But the high depression and anxiety scores were really, the FDA required us to limit. We had to set, they actually wanted a much lower depression and anxiety score number. And we had to argue like, this is a population that has just baseline pretty high depression and anxiety scores. So we negotiated to sort of severe, to be able to include mild to moderate, knowing that they are integrated in our clinic, they're seeing us, we are addressing all of these things at the same time. And again, I realize that their goal and function is to keep people safe, and I appreciate that, and I appreciate the hard work that they do. But that was a decision made for me. With some negotiation and some pushback. But I think to your point, it does help us. Are we treating, does micronized, I've been asked, does micronized progesterone treat depression? I don't think so. We didn't see high depression. We didn't see any signal there either. We've looked at that. In round 2, right, in STUDSy, will we see a signal with allopregnanolone, which is FDA approved for the treatment of postpartum depression? I don't know, and I will quite frankly say I hope so, right? Because if you can prevent people from sliding into postpartum depression or anxiety, that is a huge benefit. So as a key secondary outcome, we are gonna look at that, assuming that the CTN decides to prioritize this and push this forward.
Thank you.
Dr. Smith, I had a question. I wonder, like, do you think that maybe they saw depression and anxiety as a confounding factor? Like, were they approaching it from that mindset and that's why they chose to exclude it? I wonder if maybe they didn't understand, that it's a continuum.
Well, yes, but really the language was about safe, right? Like these are, there was a lot of concern about progesterone potentially exacerbating depression or exacerbating anxiety. And so I think that it was, in our conversations with them, I think it was really around safety concerns for the participants. I think they are also, concerned about study design and making sure that we're doing the best study that we can. But really in our conversations with them is truly around safety. Okay.
I have another
Well, thanks for
question.
all of, oh yeah.
Actually, I like that you guys I like the angle of this focus on the prevention. I know even though it's all the alliteration that you saw, because I feel like that population gets kind of lost sometimes with clinical trials. A lot of times people want to fund that people who are actively using and not want to look at people who have reached a period of abstinence or at least low levels of use and trying to reduce recurrence of use. But I was wondering if that angle was hard to sell when you were going through the grant and FDA process, and what level of that perspective is going to be incorporated into the next study.
I mean, I don't know. I mean, it got funded on the first try. So I will say that. I mean, I'm extraordinarily like grateful for that. So we sold it enough that they funded it on the first try, which was great. And I think I do think that selling it as this is specifically a period where we know people like right as a mammal, you are going to experience a lack of progesterone. Like that will happen to you if you are a postpartum person. And saying like, okay, we're now going to give that back potentially as a mechanism. I think that really was the key seller, and that this was based on data from other. So there's, I presented the 3 trials that are specific to postpartum people, but there's a whole mountain of literature that this is really built on, of people looking at progesterone in the luteal phase versus the follicular phase of menses, animal data, human data. I mean, this is, I certainly did not pluck this idea. I did not come up with this idea. I borrowed this idea very squarely from other researchers really looking at this. So I think that's really what sold it, is that it's, built, and that's how research works, right? That's how science works. We build, we're never working in isolation. I know this is like, I'm preaching to the choir here, but really it is building upon that really in-depth, many studies looking at this as a potential preventative pharmacotherapy. So I think that's really what sold it, and saying exactly like this is and if this is, and there's been really mixed data for non postpartum people, because I think again it's that like luteal phase versus follicular phases are really hard studies to do. But in the postpartum period, we know you're going to experience a postpartum drop. Like that will happen every time, right? Because having a placenta is dumb, and we should have been platypuses, which I say is an MFM all the time. Like we should have laid eggs. Having a placenta, really dumb. I'm sticking with it. It's why I'll have a job for the rest of my life. But using that specific physiology and then having a targeted intervention, I think was the novelty of this. And with that, the MFM says, don't be a placental mammal, lay eggs, be a platypus.
Well, thank you,
If
Marcela.
people,
Excellent. I appreciate you doing this for us for this journal club. So thank you very much.
Thanks everyone for coming. I really appreciate the attend. I love the questions. Thank you.
Yeah. And we'll see everyone in a few weeks for our next journal club on March 3rd. Bye.
Okay. Bye. Thanks everybody.
Thank you. Definitely stealing the platypus idea.
Oh yeah, placentas.